Hi, everyone. I welcome all of you to this Ed Talk session in which we will be discussing fertility preservation for oncofertility. We must remember that we have fertilization of fertility for various kind of patients. And this is something which we keep doing on a daily basis in our IVF clinics. And today we are going to discuss the subject on fertility preservation in cancer patients. So today I have with me Professor Eileen, who is a well-known distinguished clinician, educator, and leader, all rolled into one. With over 2 decades of academic, clinical, and organizational contributions to the field of obstetrics and gynecology, her focus has been on reproductive endocrinology, infertility, gynecological endoscopy, and menopause in the Philippines and also all over the world. She has contributed a lot to editorial responsibilities, and currently she's one of the associate editors in the editorial board. Actually, she's deputy editor of Fertility and Reproduction, which is the official journal of Aspire. She has received various awards and distinctions which she has received from various groups. And if I go into it, I'll be running into pages. So I'm going to speak briefly on that she has numerous publications to her credit, and besides having contributed a lot to medical education. More than anything else, I know Eileen personally. I meet her at various conferences, and believe me or not, she's such a brilliant singer that she takes charge of the entire entertainment in the conference, and she puts all the professional singers to shame. So welcome, Eileen, to this.
Thank you, Duru. My voice is croaking, actually. I just had a bout of URTI, but thank you for the kind introduction.
So today, when we are talking about the ovarian stimulation protocols in patients who have cancer, it's a very painful decision for us to make and to talk to the patient. And it's very painful for her to also listen to what we have to say. And she has to quickly make up her mind that she needs to freeze her fertility before, the treatment of cancer starts. And she knows that she will have to move in quickly, and we know we have to move in quickly and freeze her eggs with least complications, get as many eggs as possible, and without harming her and aggravating her cancer. So there are too many challenges. And we'll start with the first thing is that when a patient comes to you, Eileen, she comes to you at any stage of her menstrual cycle, and you decide that you want to freeze her eggs. And she tells you, Doc, you can start tomorrow. What do you do?
Start tomorrow. Okay, this patient needs about 2 to 3 weeks of stimulation, usually average of about 11 to 14 days. So we have this much time to try to get the most number of eggs, the most competent and mature set of eggs in the shortest possible time. And so we can do a random start stimulation, which is the most common stimulation that we use in oncofertility. And what does that mean? It means that you don't do the conventional day 2 or day 3 starting of your stimulation. The moment you see the patient, whether she's in follicular phase of the cycle or luteal phase of the cycle, you do your baseline ultrasound, you do your tests, and you can literally start the patient on your gonadotropin stimulation. And we can, of course, use antagonist cycle, antagonist protocol, or the PPOS protocol, which are the most commonly used, and we can talk about that further.
Yeah. So when you start randomly in any part of the cycle, does it make a difference compared to the conventional protocol we use for ovarian stimulation and IVF? Because you're starting halfway through a cycle, you're starting on any day of the cycle. So can you talk a little about how you do it?
So this is a very good question, because you think, well, if you do a random cycle, you might not be getting competent oocytes at the end of the day, or you might be getting less. But studies have shown that the yield from your random start protocol is actually just as good. No, it's comparable to the conventional protocols that we're using. And so in terms of the oocyte yield, the number of mature eggs and the number of competent eggs are actually comparable. And whether you do it in the follicular phase or the luteal phase of the cycle, the outcomes are the same. Although some say that you have better yield if you do it during the luteal phase, but pregnancy rates and live birth rates are more or less comparable.
Yeah. So when you do it in the follicular phase, we know that we normally start stimulation on day 2, 3 of the cycle. But suppose
Mhm.
they come to you on day 10 of the cycle, and she's about to ovulate. What do you do in such patients?
Well, you can actually give an antagonist at the start. Okay.
Yeah.
And this is nice because this is that would mean that you'll probably need less gonadotropins to bring about your yield of oocytes. And you start your antagonist, you give your gonadotropins, you can give HMG, you can give your combination with whichever, depending on the age. Of course, we're dealing with young patients here.
Mm.
And when you get about 3 or 4 oocytes measuring about 17 or 18 millimeters, then you're ready to trigger. And here you trigger with your GnRH agonist. And the whole purpose here is you want to avoid ovarian hyperstimulation because this is such a no-no when you're dealing with these cancer patients. Remember, you want these patients to start their chemotherapy or radiotherapy the soonest possible time. And developing OHSS is not only potentially lethal, but it delays the treatment. That's one. It also predisposes them to higher coagulopathy state, and so that can predispose to thrombosis. And so you don't want all these complications setting in, and so you give your GnRH agonist as a trigger.
Okay. So in short, also, would you like to use any other adjuvants to prevent any, too much of an estrogen rise during your
Right.
stimulation?
That's a very good question. So a lot of these patients, well, of course, breast cancer is still the most common among our patients. And so with this, among patients with hormone-dependent cancers, you try to minimize the estradiol levels of these patients. And so we give aromatase inhibitors, and most commonly we give letrozole, okay, 2.5 or 5 milligrams together. So as a co-treatment with gonadotropins until the time of stimulation of trigger.
Of the trigger. So what is the
Yeah.
dose of letrozole you use, or would you prefer tamoxifen over letrozole or letrozole over what do you prefer?
You can give tamoxifen because it's also anti-estrogen, but studies have shown that letrozole actually gives a higher yield, more mature oocytes,
Yeah.
and even estradiol levels are lower with the letrozole. So usual dose is about 5 milligrams per
Yeah.
day. So that's 2 tablets of the 2.5 milligrams.
Yeah. And you add the gonadotropins on the same day as the letrozole?
Yes, so you give the letrozole and the gonadotropins at the same time, and then you start your antagonist when you have a lead follicle about 13 millimeters in diameter, and you continue this on up to the time of the trigger.
Yeah. In a younger patient, say if she's about 32, 33, and you have to start this therapy, what is the starting dose of gonadotropin you use?
Well, depends. It's still on the AMH and the BMI of the patient. So higher AMHs would require, of course, lower doses. Still, you can start with 150, in these young patients. Um, Generally, of course, we don't really encourage fertility preservation in older patients, but the ruling it's actually very flexible. If the patient really wants to go for fertility preservation, even if she's much older, even if her ovarian reserve is not so good, if she wants to do it, then of course, so be it. We follow. So it still depends on the patient's age, the ovarian reserve, her BMI, and so on.
Yeah. So the concerns are that, you want to quickly get the eggs out and you want to get maximum number of eggs and you want to make sure that she's free within 2 weeks so that she can go through her cancer treatment. But
Right.
the question was that what is the dose if it's a younger patient, say she's 22, 23, and you need to preserve her eggs. What is the highest dose you've used till now for such women?
Well, probably just 225. I mean, you start with 150 and work your way up. So it's
Yeah.
only in those patients where they're not responding very well that you because you don't want these patients to hyperstimulate. You want to get, so these patients will probably need about 50 or 75 IUs more of their FSH compared to non-cancer patients, but generally you don't want to give such high doses to predispose them to OHSS.
Absolutely. So keeping that in mind, I think we need to understand that we don't need to hyperstimulate women. We can
Mhm.
use adjuvants to help these women, and we
Right.
use those based on the AMH and ovarian reserve, and we
Mhm.
try and reduce the amount of dose you would have otherwise given conventionally, and in this
Right.
you would have a little lower dose. So
Mhm.
now, if you want to freeze more eggs and you've got not enough eggs, in such patients, would you consider doing a duo stimulation?
Yes, definitely. So this is something we offer to patients if we have the time, because the dual stim will take up 2 cycles, right? So yeah, so if we have enough time, more than 2 weeks, then we can do that. So dual stim is something that we offer to patients with diminished ovarian reserve, the cancer patients who have a little bit more time for their stimulation. So we do the first half, during the follicular phase, and there are 2 ways of doing it. There's the Italian protocol by Orelli, and the other one is the Kwang protocol. But generally, if it's the Italian protocol, you wait for 5 days from the ovum pickup, and then you start another cycle. Okay, from my experience, it takes a shorter time to do the stimulation in the second half of the cycle, although the literature would tell you, you need more gonadotropions, you need longer stimulation. But my experience is otherwise. I usually see get more yield with less number of days of stimulation in the luteal phase.
But the question is the outcome of, I mean, the quality of the eggs or the number of eggs equally good as you would get in the follicular phase?
Well, I've told you this earlier. So studies have shown that you actually get equal pregnancy rates and live birth rates, but some say you might get more oocytes, more competent oocytes, higher yield in the luteal phase. And actually, that's also my experience.
Okay. So in your experience that you get a better luteal phase sort of
Outcome.
uh, group of eggs which are better and
Mhm.
more comparable to even the conventional ovarian stimulation.
Mhm.
Now, how much is the time you like to wait between the two stimulations? If you're doing one in the luteal phase and then in
Yeah.
the you do in the follicular phase, right?
If after the luteal phase, you might even want to wait for the pregnancy, I mean, for the menstruation to come in. But usually you start the patient in the follicular phase, wait
Yeah.
5 days. After the trigger, you do your ovum pickup. Then 5 days later, you start the stimulation again. You will see a lot of corpora lutea there. Don't worry about that. And you will see some developing follicles usually by the fourth or fifth day of stimulation. And as mentioned, it might take longer, but as I said, usually in my case, I see about 10 to 12 days would be sufficient, or sometimes even less, to get the yield of the oocytes. And then, of course, the trigger that you use is still going to be your GnRH agonist trigger.
Does the corpus luteum of the previous cycle, the follicular phase cycle, come in the way of doing the luteal phase cycle?
Sometimes it can be so confusing. So
Yeah.
yeah, so it gets more difficult actually to do the stimulation in the luteal phase, but you get the hang of it. So as you do more cases, you will see fresh follicles developing
Yeah.
despite, right next to the corpora lutea, and it shouldn't be too much of a
Yeah.
problem. Yeah.
There have been some cases reported that when they entered into the corpus luteum, they could sometimes create infections. Have you noticed anything like that?
No, I haven't encountered that. But I can
No.
imagine it is possible, yeah. Hmm.
Yeah, okay. So coming to, there must be advantages and disadvantages of duostimulation, right? And advantages and disadvantages of both the follicular phase stimulation and luteal phase stimulation. So have you any personal experiences of what you have found? And what you said you preferred follicular phase starting, but question is, what are the advantages and disadvantages?
Actually, the advantage of doing the dual sim is that it allows you to do two cycles instead of just one. I mean, two stimulations in one cycle, so you get better yield that way. Cost is a consideration, and some patients, of course, complain, of discomfort, especially after having gone through the
Yeah.
ovum pickup and then having to go through this again. But you tell them, I've had good successes with patients going through the duostim, and we've had pregnancies with this, and it's actually very encouraging for the patients. In terms of disadvantage, and I think they're equally good whether you start on the follicular phase or the luteal phase. Doesn't really matter.
Do you ever get patients where after the follicular phase stimulation and you have given her the agonist and then they start getting their periods? Does it come in the way of your luteal phase stimulation?
No, it shouldn't because you're not going to do a transfer. Okay, so
Right.
it doesn't matter, right? Mhm.
Yeah. So it's not a problem if she gets a period, you can still go
Mhm.
ahead and
Yep.
start with.
Yeah.
But
Mhm.
frankly, preferably with my experience, I like to wait for 5 days rather than 3 days. There are some people who wait 3 days,
Yeah.
and somehow, I mean, some wait for 5 days. I prefer waiting 5 days because I think everything gets clearer after the agonist is given and things settle down faster instead of
Exactly. No, but
using the trigger.
initial literature was actually suggesting do it after 3 days. But later
Hmm.
on, we had more literature coming out from Ubaldi saying that, you wait for 5 days and you get better outcomes that way. And that's what I
Yeah.
follow. Yeah.
Yeah. Okay. So the other question I have for you is, what do you use for pituitary suppression? You prefer the antagonist, obviously, but
Obviously, because it's a lot more convenient. So especially for oncofertility patients, then
yes.
it's a lot safer, and you don't have to downregulate the patient. So it takes a shorter time. So it's more flexible, and cost-wise, it's actually less because you use less gonadotropins, less stimulatory drugs in the process.
What do you think about the progesterone primed stimulation?
Oh, so we're using it. Okay. I mean, it seems to be comparable. In terms of premature suppression, premature LH surge, results are supposed to be comparable. Although I do feel that I have more confidence using the antagonist as far as that's concerned. So if I feel like if I'm using, say, MPA and I know that there's a risk of premature ovulation, I would give additional antagonist in the process. But studies have shown that oocyte quality, competence, maturity, they're all the same, whether you use the PPOS or the antagonist. And of course, you have the advantage of cost, cutting down on cost if you're using this oral medication with PPOS.
I think the problem would occur if the patient has a breast cancer, which is progesterone
Right,
receptor positive.
right, right.
Then
So
you may want to,
you wouldn't want to give that, of course.
yeah.
Yeah. Hmm.
So I think that is another area we have to keep in mind.
Hmm.
There are instances where they say that it's important for you to do the typing of for the genetic makeup of the tumor because there are some mutations in which women who undergo cancer therapy after fertility preservation, they develop amenorrhea completely, provided, I mean, if they have those mutations. Do you tend
Right. So,
do you tend to do that? But how
yeah.
would
So
yeah, go ahead, tell me.
no, we don't do that routinely. I mean, it's not cheap, checking for the BRCA. But in patients who have a very strong family history, of course, we offer that. And we know that BRCA patients are predisposed to earlier menopause, and so it's important to check their ovarian reserve. These patients,
Yeah.
because they have lower AMHs, lower antral follicle counts, they use more gonadotropins, and yeah, so these patients have to be advised, and you have to get them early because they really are at a risk of a higher risk of premature ovarian insufficiency or even premature ovarian failure.
Yeah. So ideally, we would like to get their mutation testing done and do the needful, but of course, it's not possible everywhere to do the
Yeah.
same.
Hmm.
Then, of course, we have finished with the suppression. Now we come to the trigger. So when
Hmm.
given the trigger, of course, agonist trigger is the choice. At least it's my choice. What about yours?
It is actually the recommended choice. You don't
Yeah.
give the HCG because you want to avoid at all costs OHSS
Yeah.
because that's
Yeah.
really going to delay your treatment, your cancer treatment.
But sometimes some people have also recommended a dual trigger. Do you believe in that?
Yeah, so some people do. So you can give your agonist. We usually use decapeptyl. So
Yeah.
decapeptyl with a low dose HCG of 1,500 units. So that also can be done if you know that your patient is not at risk of hyperstimulation. Yeah, you can do that.
Yeah.
Studies have shown that you have higher oocyte yield that way. That's
Okay.
being contested, by the way, now.
Yeah.
Yeah.
Yeah, I mean, there's so much of controversy in this whole area that read different literature. Of course, the guidelines state something standard, but when you read new
Mhm.
literature, it comes up with different modifications. So it's each one's own
Mhm.
experience how we have found what works better. The other
Yeah.
question now I have is post-freezing, once you've got the eggs frozen. Have you had any pregnancies after using those eggs? How did you find your outcomes? What are the challenges faced, or do they do as well as the regular oocytes which are collected? Does it make a difference to the live birth rate or the blastocyst rate? Anything?
Yeah, so the results are really comparable. So unless you're dealing with patients with systemic cancers, so systemic illnesses, these patients do a little bit more poorly and will require more gonadotropins. But if you're dealing with the young cancer patient going through ovarian stimulation, having gone have frozen their eggs, or if they are partners, the embryos, they do equally well. Okay, so there's no reduction in the live birth rate or the pregnancy rate. And there's no increase in recurrence rate as well. So even in patients who've gotten pregnant as a result of their ovarian stimulation, these patients also have not had any recurrence or worsening of their illnesses.
Does it make a difference to their cancer? Any patient where the cancer has got more aggravated after the freezing process?
No, unless you're dealing with a very, very what's the word for it? Very aggressive cancer. And anyway, if you're dealing with a very patient with aggressive cancers, you're not going to offer controlled ovarian stimulation. You're going to do the ovarian tissue freezing, right?
Yeah,
So these
yeah.
are patients who can't wait, and so you have to be able to give them the cancer treatment straight away.
And if she's a young girl who's not even reached puberty, a child
Yeah, that's
who's come,
that's
so you
she's
prefer complete ovarian freezing or the cortex freezing?
either. So it really depends on the size of the ovary. If you're dealing with a very small ovary, you might have to use the entire ovary and freeze it, cut it into small pieces and freeze it. But
Yeah,
otherwise,
yeah.
yeah. So you can do either.
Either of them, yeah.
Mhm.
So in short, what do you see as the future of freezing of fertility for
I
cancer?
think there is so much, the future is great for these patients, and we can offer this, and it's wonderful. So, fertility preservation has been around for 20 years. It's actually been only introduced in our country in the last 4 or 5 years. Okay, so we have now our own fertility preservation society, and we're trying to incorporate this in medical school so that even the general physician can know that once you diagnose a patient with cancer, you have to refer the patient to a reproductive medicine so that we can really, try to harness their fertility potential. It will be a bad thing if they just come to us, way too late. And of course, if the patient has had one episode or one course of chemotherapy, she can still be amenable for fertility preservation. So it doesn't mean that just because she's had, treatment that she's no
Yeah.
longer amenable for fertility preservation. Yeah, so we need to educate our
Yes.
doctors.
So I think we need to educate our patients, we need to educate our doctors. The reason is there's so much fear about cancer that the word cancer, they want surgery tomorrow. And they're not willing to wait for any thing. And I think that stands where everywhere in the world that people are worried. And therefore we need to sort of create that awareness all over the world. So thank you very much, Irene,
Right.
for
And
being with, and it's been a wonderful
thank you.
session to you, and having this Ed Talk, which is through Aspire. And we've had such wonderful talks, and these small episodes help people to listen to small snippets of focus talks, which are very important in management of our patients. So I thank Aspire for giving us the opportunity to have this session.